All right. Well, thank you all so much for joining us this morning and some of you this afternoon for our call today on the T1 Detect screening program that JDRF is rolling out. I'm really excited to be a part of this opportunity. I know that we've been working closely with JDRF and the DAI on some projects recently. And so when this was presented to us as an opportunity to be involved, we were more excited, we were more than excited to share this opportunity with all of our partners out in our communities. And so I just wanted to take a couple of minutes for introductions. This was kind of an offset of our virtual trainings, one that wasn't necessarily on our calendars. So I'm so glad you guys were able to make it. As a reminder, we do have our next virtual training on July 14th. Information can be found on our website. I actually will do a quick screen share. No, I won't. It's not. Oops. That's not. There we go. Okay. Quick screen share so that you guys know. Visit our website, event information. You can access all of our events and register for them within this section. We are recording our sessions. And so if you would like to access those at a later time, you would just go into resources and information and provider resources. And then down at the bottom, we'll keep uploading our recorded sessions for you all. So with that, I'm going to stop sharing here. And then feel free to use the chat to submit any questions you have for our speakers. I think that there'll also be opportunity for question and answer towards the end, and then a little bit more information that will be coming out in the conclusion and in our follow-up emails. So with that being said, I believe that I get to hand it over to Dr. Martin, who is joining us from JDRF research team. So Dr. Martin, thank you so much for joining us, and I'm going to hand control over to you.
Well, thank you, Ashley, and thank you to your colleagues for hosting us today. I thank you for the opportunity to be here. And while yes, we've launched a cool new program called T1 Detect, we really wanted the opportunity to try and begin to educate you and your colleagues about the hows, whys, the needs around T1D risk screening. And for that, I've enlisted some outside help from my colleague, Linda DeMeglio here. And we are going to talk about some of the history around T1D, where we started from, where we are now with what is known with clinical care these days in treating patients who are in what we call stage 3 disease or even established T1D, where there are discrepancies in the care or failures in how we're treating those patients today. And then we're going to transition to really how we are dealing with people in the at-risk situation, how we are identifying them, how we monitor them. And mind you, this is all in the context of research settings. There are no overt clinical care guidelines here, but people that JDRF have funded, the NIH have funded, organizations like TrialNet that Linda works as part of, have spearheaded efforts to identifying and monitoring these people. So we want to share some of the learnings from that with you, and then leave you with some resources that you can use to educate yourselves and your colleagues on what is known about T1D risk screening and monitoring. And I can't forget to say what a valuable resource we have with us today in Linda. She is someone who is working in this herself right now. So I hope that you'll really take advantage of the Q&A portion of this. And we're a rather small group, so I'll do my best to keep an eye on the chats. And if we can, we'll answer questions as we're going. I'll do my best to talk as slowly as I can. I tend to get a little hyper and talk quickly, but you know, feel free to stop me along the way if you have a huge question. But I look forward to an open conversation on this important topic. Okay, so by way of further introduction, as I pull up my slides, I am a PhD scientist. My training is in pharmacology and immunology. I've been working here at JDRF for 7 years now. And my primary focus areas here at JDRF have been first, the development of therapies that can help slow, halt, or reverse the progression of type 1 diabetes. And I'd focused primarily around those therapies that target the beta cell, and trying to find therapies that can really improve the health of the beta cell or camouflage the beta cell from the autoimmune attack that happens during the course of type 1 diabetes. And a lot of those areas that I manage are research projects that occur in the academic setting, and some of those are in the clinic right now. Some of those are clinical trials that have been run through the TrialNet consortia that Linda is a part of, another consortia. Anyway, over the course of the last year or so, I've also taken on another hat at JDRF, a couple other hats. One of those is I manage the research programs around screening for T1D risk. So that is, how do we best identify people in the population who are in their future going to develop insulin-dependent type 1 diabetes? And we'll talk more about how we do that. In addition, I've had the opportunity to be part of the launch of a real-world setting test of what we've learned in research, where JDRF and one of our corporate sponsors, Provention Bio, are making education, awareness, and actual test kits available for people in the general population who want to get screened for their risk of type 1 diabetes. And we'll talk about that more later. And so now I'll hand it over to Linda for her to give her an introduction about herself, her history in working in T1D, and what she does now, and what her institution does now for T1D.
Thank you, Frank. It's a long list. You have to like guide me through what you want me to talk about. I like kind of phased out after like the third thing. I was like, so I'll just introduce myself and you can tell me if I missed anything. Sure. So I am, I'm a professor of pediatrics at the Indiana University School of Medicine, where I run a research team that is focused on the prevention of type 1 diabetes, for preserving beta cells for people who have established new onset disease, and then also diabetes prevention and treatments. And I've been doing that work with this team for the last 11 years. Previous to that, I was, as I told Frank the other day, like I was JDRF funded at the beginning of my career. So I started my career with about 25 years ago here at IU with a study of insulin pump therapy in toddlers with diabetes. So I'm very passionate about using technology, especially in underserved groups. And now I'm very excited that we've gotten to the point, as we'll talk about, that we have some therapies that have actually been shown to be effective for delaying the onset of type 1 diabetes and preserving beta cell function. And so we are at the point now where doing things like screening for diabetes makes sense, because I also got my MPH as part of my career development. And in that role, I learned a lot about screening and newborn screening, and initially started in newborn screening for things like congenital hypothyroidism and congenital adrenal hyperplasia, so endocrine disorders, but now I get to apply it to diabetes in a different screening setting, and it's been a great adventure. I also do a lot of work with guidelines. So part of what I'll talk about today is some of what is needed to inform those guidelines. So right now we are at the point where we're ready to screen, and Frank wanted me along for the talk today to talk a little bit about what we do with those results if we get screen results that are positive, but we're on the cusp of being able to figure out what evidence we need and what evidence we can collect in partnership with groups like JDRF to be able to do what's evidence-based around monitoring and around treatments for patients prior to clinical diagnosis of type 1. So that's kind of who I am. And like I put in the chat, so since Frank and I are going to tag team during this presentation, and either one of us could have given the other half of the presentation, if you've got questions as we go along, either raise your hand, and I'm assuming Ashley will monitor that and like wave at us, but because that I won't be looking at, I can't watch that, but we will be watching the chat when we're not talking. And I hate that these are not interactive, because so please like ask questions as we go along, and we'll be happy to answer them.
And I'll be driving the slides. So Linda, you did a great job. I'll be driving the slides. So Linda, you just tell me when to push them forward.
Okay, perfect. All right. So this is a slide that I actually borrowed from a colleague at Yale who, and I update it every year. And I just like to talk about where we are, especially as we're coming up now on the 100th anniversary of the discovery of insulin. On the left-hand side, you can see Banting and Best in Toronto. They were a research scientist and a medical student who pioneered the discovery of insulin, looking at pancreases of dogs. So it's one of their dogs there in the picture. Interestingly, Charles Best was not listed on the Nobel Prize because he was a medical student. So it was Banting and McLeod that got the Nobel Prize, and some of you know that already. But there's a lot of really good articles and some really great free symposia you can get information on around discovery of insulin. It's been a really exciting year. And then we can fast forward from the discovery of insulin to my childhood during the 1970s, when things like glycohemoglobin first became available. We had more concentrated insulin. So you'll see there a U80 insulin. Most of you know that this now U100, and a prototype insulin pump on the bottom. And we couldn't yet test blood for blood sugars in the early 1970s, but we would do urine testing for clinic testing for glucose. And that was what people would do and get their blood drawn about once a month. And now if we go forward to 2021, where we are today, we have a whole plethora of pumps and sensors and glucose monitors and different types of insulin and all this stuff that was really space age even when I started 25 years ago. And but yet our families still struggle, and there's still a big burden of care. So we'll go into next slide. So despite that change that I showed you over the last 100 years, we have far to go to optimize therapy and quality of life. And almost every talk I give, I use that first slide, but I also use this statement from the American Diabetes Association, which I think holds just as true now as when it was printed, probably in like the 1980s, based on the font and but insulin is not a cure for diabetes, but keeps people alive until we find one. So we're all here because we're interested in diabetes and because we all want to make lives better for those of us who live with diabetes and also our patients with diabetes. Okay, next. So we're just going to briefly start by talking about the pathogenesis of type 1. I know most of you are familiar with diabetes already. I would say the pathogenesis of type 1 is associated with T-cell mediated attack on pancreatic beta cells. People are a little divided as to whether that's causative or the beta cells are wimpy, and that's why the T cells attack, or whether or not the T cell attack is the primary driver. But either way, it's autoimmune disease, regardless of what's the trigger. We know that there are multiple genetic and environmental factors that contribute to diabetes development, and they probably even vary within family members who get diabetes in the same family. But in general, you have to have a genetic makeup that makes you predisposed to develop type 1, and then it's probably something in the environment triggers it, although the trigger may be months or years prior to clinical diagnosis. It's a very slowly progressive disease. That's something I did not appreciate until I started doing this work about 10 years ago, that diabetes is really a relapsing remitting disease in some ways, like MS and like some other autoimmune diseases we think about. And so people actually do go from dysglycemia to normal glycemia to dysglycemia to normal glycemia with an inexorable progression toward diabetes over time. But when you watch people, and that clinical diabetes development can take months, we certainly see it unfortunately in some babies, children that are 9 to 12 months of age can develop type 1 diabetes, obviously, and that was very fast. I also followed a patient myself who was about my age when she was diagnosed with diabetes now, so she would have been diagnosed I'm in my mid 50s now, but she would have been in her 40s, about the same age as me when she was diagnosed. And she had been followed through some of these screening studies for about 20 years and had autoantibodies for 20 years before she developed type 1. And actually wasn't even on insulin for about 3 years after her clinical diagnosis based upon glucose tolerance testing, which I think was very interesting. But you can find multiple pancreatic autoantibodies. We'll talk more about those from a few weeks up to 20 years before onset of disease. The rate of beta cell destruction varies. So we know, for those of you who take care of children, that that kids have very short honeymoon periods, if at all, after the diagnosis of type 1, where they maybe have low insulin requirements or actually be insulin independent. Older people, adults, it's much slower, like that case I told you about. And the most common presentation is with absolute insulin deficiency, leading to high blood sugars, drinking more, peeing more, so polyuria, polydipsia, and can be associated with diabetic ketoacidosis, which we'll talk more about. Next slide, Frank. So I think it's also important, this slide I think says a couple things. One is that type 1 diabetes is a little bit more prevalent in males than in females. It's not terribly much so. Like here at Riley, we're just looking at numbers earlier this week, we're about 52% of our kids with diabetes are boys versus 48% girls. So it's just interesting that more common in boys. Most autoimmune diseases are more common in women. So this is a little bit different about diabetes. And then what you can see here is that the peak in age at diagnosis in the teenage years, some curves will extend a little bit more to the left, and you sometimes can see another little peak in younger patients as well. And then a less of a peak, but still a sustained incidence of type 1 diabetes throughout adulthood. And some people estimate that half of the people that are diagnosed with type 1 are diagnosed with adults. So for those of you who take care of adults who think of type 1 diabetes as a pediatric disease, it's not necessarily that. And even JDRF rebranded themselves for different reasons than Kentucky Fried Chicken, who went to KFC. Similarly, JDRF rebranded to JDRF versus the Juvenile Diabetes Research Foundation to kind of focus, to keep the history of the name. I think, Frank, you could talk more about that than me, but also recognize that it's not just a pediatric disease. And then the important thing here is that your incidence, it's hard to calculate. I have an MPH in epidemiology, and I can't even like do that in my head around the incidence, but it's also the most common chronic disease of childhood, type 1 diabetes. And so those incidence rates are actually also fairly high. So we usually say that about 4 in 1,000 children will develop type 1. So it's not something that's rare. So all of you have seen people with diabetes in your practices. Obviously you're here because you have an interest in diabetes, but although it's about 10% of total diabetes, it's not a very rare disease either, type 1. Next. And it's important to recognize that the incidence of type 1 diabetes is increasing worldwide. So the type 1 diabetes incidence in new cases per year is doubling about every 20 years. And on the left-hand side, you can see case rates over time in 4 countries. So Northern Europe has the highest rates of type 1 diabetes in the world. So Finland and Sweden are highlighted there. They also have great national registries where you can get all this data, and they do some amazing epidemiologic work. Colorado is there as a site that is part of the search consortium, but also looking at rates over time, and the rates in Colorado have gone up, and then Germany, similarly other places are going up over time. The left-hand graph I just think is kind of cool, and it's from a paper that shows that even though it shows you kind of that same peak that was in the last slide. So you see that peak in incidence around 10 to 14 years of age, and then going down. This only carries out to 30 years of age. Again, you see on the left-hand side, higher rates in males than in females. But those kind of colors that look like a rainbow of color go from the darker, cooler colors being older data back to current data. And you can see up to current data rather in the red. And what you see is a shift, like a leftward shift on that spectrum. And that is the rates of incidence of diabetes, again, going up over time in both males and females and across. Now there they only have the younger, the incidence rates were calculated by the age at which the people were diagnosed at various time points. So the people who were diagnosed in the 1950s were older, different things like that. It's a weird graph, but it shows you again that shift to the left, which indicates there an increase in rates of diabetes. Next. So our goal for all of us who are diabetes educators or nurses, or for me as a physician, is to reach glycemic targets. And here I just show you the pediatric targets. So their pediatric targets for children are associated with different pre-meal, post-meal, and pre-bed blood sugar ranges. I can tell you that I made up the ones for ISPAD. So this is from guidelines that I was first author on a few years ago. And I imputed them based upon what the ADA has as their pre-meal goals, and the NICE had their pre-meal goals. And I went in the middle because at the time the A1C goal for children used to be 7.5. But any of you that care for children, everyone should be aware that that goal, the target now for children across the board for ADA and ISPAD is less than 7. There's some push to take it down to less than 6.5 in kids. I don't think that's going to happen. You who are care for adults know that range of 6.5, but it's important to recognize that we're trying to get there for goal. And the next slide will show us how we're doing in relationship to those goals. So this shows you the goal at the time by age. So now it's gone down to 7 from 7.5, but you can see here on the left-hand side, the age in years on the x-axis, A1C on the y-axis. And on the left-hand side, you can see the goal for pediatrics at the time was less than 7, and the goal for adults was rather less than 7.5, and the goal for adults less than 7. And if you go forward, Frank. So this is where we were in 2010, 2012. You might say, Linda, you just showed me this curve and it was an incidence curve. This is not incidence, this is like A1Cs. And you can see that the peak A1C here in late adulthood, when our adolescents are become less compliant with care, and also just their schedules are changing, their insulin sensitivity is changing, their A1Cs go up and then they come down. And I'm always dismayed as a parent currently of a 19-year-old that they don't get to kind of adult values as far as steady until like in the late 20s, but and then it stays fairly stable. And so we looked at these data back in 2010, 2012. These are data from the Type 1 Diabetes Exchange Registry, which was a group of 75 sites that were taking care of children and adults with type 1 diabetes. Of interest, this is what A1Cs look like when these patients are taken care of by endocrinologists. So this did not, any of you who are at a primary care practice, if you take care of children and young and adults with type 1, they would not be in here because this was all endocrine data. And then if you go forward one more, this is what it looked like in 2016, 2018. So the A1Cs actually got worse over the time period. So despite an increase in like CGM use, an increase in pump use, the newer insulins, kind of what we had, the A1Cs actually got worse over time. Now, some of this is because the population got a little older, and as you are older, you have less of your own, you've been further out from diagnosis and you have less endogenous beta cell function, but that was not enough to explain like this difference. And this was very disappointing and indicates that we have a lot of work yet to do. Next slide. All right, so here I'm going to turn it over to Frank.
Thanks, Linda. So I don't want to leave you with, now that I'm transitioning to, or we're transitioning to talk a little bit more about the pre-diagnosis setting. Let me not leave you with the impression that we're not doing anything about people after diagnosis. JDRF, others, people like Linda, there is loads of research going on to address the data that Linda just showed. Therapies in development, device work being done, et cetera, et cetera. We know that those things need to be addressed. People living with the disease need better therapies. They need better tools to help them control their diabetes better. They need cures for the disease. But there are other ways that we can address the public health need or public health problem that is type 1 diabetes. We can start earlier. So we can prevent the disease. Ideally, we can prevent the disease. And one of the first ways to prevention is who and how can we identify the disease. So many of these amazing researchers have been working on observational studies to look at signs and symptoms of autoimmunity in the circulation of people in the general population or in families that have type 1 diabetes in their families. And they found that there are a number of autoantibodies that are specific to pancreatic and specifically beta cell, insulin producing beta cell proteins that show up in the circulation of people. 4 of these in particular are good prognosticators of your future risk of developing insulin dependent type 1 diabetes. In fact, as was shown in this 2013 paper from the analyses of a German cohort study called the FRIDA study by Annette Ziegler, that if you have 2 or more of these autoantibodies in your circulation, your lifetime risk of developing type 1 diabetes does approach almost 100%. The numbers are closer to 80 or 90% on the time horizons they have here at 15 years. And but we know that really once you have 2 or more of these, your lifetime risk is very, very high. So we and others started to use these as ways to stratify people into monitoring studies. Can we identify these people in the population to either monitor them better or to recruit them into clinical trials for putative interventional studies? But the important take-home message is this and other studies have shown that measuring specific islet autoantibodies is a very good prognosticator of your future risk of diabetes, of type 1 diabetes. And this went on to be further specified into staging type 1 diabetes. And now with the presence of 2 or more autoantibodies, we can say that a person has demonstrated autoimmunity, and they've really entered the start of type 1 diabetes. They actually have type 1 diabetes, just an early stage. And this means that their immune cells are active against their insulin-producing beta cells. And we now see the signs of that as autoantibodies in their blood. This eventually progresses into beta cell dysfunction that can be measurable as abnormal blood sugar through oral glucose tolerance tests or equivalent. And once a person has this, despite being asymptomatic, they've entered stage 2 of the disease. And in fact, once they've entered this stage of the disease, their risk of progressing to insulin dependence has increased dramatically. The time horizon towards that has become shorter. We know that they are very likely to convert to insulin dependence. And indeed, they'll move on to stage 3, which is insulin dependent type 1 diabetes, what we have classically called T1D, but in fact is the 3rd stage of the disease. This is a figure explaining the process, basically stolen from TrialNet, but it explains it perfectly. And this is a very good way for us these days to look at, well, what are the needs of the different people in each of these populations. There might be different treatments that will help address what a person in stage 1 needs versus a person in stage 3 who might not have a lot of insulin producing beta cells left and rather benefit more from a device-based therapy or a cell transplant-based therapy when those become clinically available. So one of the benefits that was seen when these programs, TrialNet, or some of the general population screening programs, started to screen people for their presence of islet autoantibodies, was that they found that when they identified these people and then started monitoring them as is appropriate for someone who's progressing towards overt type 1 diabetes, they found that it was able to reduce the rates of DKA at diagnosis. Unfortunately, in the United States, DKA at diagnosis is a rather common occurrence, with reported rates as high as about 60%, with an average more around 40 to 50%. Unfortunately, DKA at diagnosis does come with a very increased mortality risk. There's long hospitalizations associated with that. And for the rest of the life of that person who's experienced DKA at diagnosis, there are health consequences, including higher insulin requirements, a shorter remission period after diagnosis, and poor glycemic control over time. So it behooves us to try and reduce this particular event that's associated with a lot of diagnoses of type 1 diabetes, in addition to the psychological impact of what it's like for a family to enter a life of T1D during this traumatic experience. Something we'd like to point out is across the world, rates of DKA diagnosis are high, but this is especially high in some of the BIPOC communities, in the Hispanic and non-Hispanic Black communities. What we're looking at here is a breakdown of the prevalence of DKA in adults. This is actually DKA in adults after diagnosis in stage 3 disease. And this is prevalence per 1,000 people. And what we see that here is, I boxed it out in red, is that actually Black non-Hispanics have some of the highest rates of DKA during their experience with T1D as compared to other ethnicities in the United States or in other analyzed cohorts, for example, Sweden. This is unfortunately not just true in the post-diagnosis setting, but also true in the at diagnosis setting, that African American people, when they're diagnosed with T1D, tend to be diagnosed during DKA situations more frequently than non-African Americans. So there are significant disparities here that need to be addressed. And we hope that with the increased availability of screening and monitoring programs, this will be one way to drive down these rates for not only the population at large, but specifically these specific populations for which these disparities exist. Now, unfortunately, disparities in type 1 diabetes experience are particularly high in Black and Hispanic populations here in the United States. And this has become a particularly high priority item to address for the JDRF and for other organizations, for example, TrialNet. So you're likely to hear more and see more in our activities about this going forward. The point I want to drive home is that we know from multiple research studies that screening and monitoring can reduce the risk of DKA diagnoses. These were prospective longitudinal cohort studies where population screening was done and then close follow-up was performed after the screen test positive. And that is what was needed to drive down the rates of DKA diagnosis. It's not screening alone. It's not just the person knowing that they have a positive test result. It's screening and that monitoring that's done with a specialist endocrinologist. Studies like this that led to that support the data are coming from older studies like the DPT diabetes prevention trial, the DAISY study, the TEDdy study, baby diab, and we have ongoing studies, active research studies that continue to corroborate this finding. So again, take home messages here. We know that DKA diagnosis is common. We know this is associated with high mortality and morbidity, and it does have a very high overall economic cost, because that cost is not just due to the singular DKA at diagnosis event. It has long-term consequences to the health of the person that are experienced by our healthcare system and our healthcare providers. So if we can drive these down, we'll actually reduce the burden on our healthcare system and on the patients experiencing these. So with that, I think I'm handing it back over to Linda.
Thanks, Frank.
Sure.
So we want to start off with where things stand right now on recommendations for risk screening. And as many of you are aware, the American Diabetes Association releases standards of care guidelines each year, and those guidelines are actually now updated more often than annually, which is very exciting. Many of us just got updates to them. I think it was last week, we got a set of updates. And in the American Diabetes Association recommendations, it addresses screening for type 1 diabetes. And this is what it says currently, that screening for risk with a panel of islet autoantibodies is currently recommended basically only in the setting of a research trial. Now, this is a little bit prior to T1 Detect coming out, but it can also be offered as an option for first-degree family members of a proband with type 1 diabetes. Autoantibody persistence is a risk factor for clinical diabetes, as Frank talked about earlier. It may serve as an indication for intervention in the setting of clinical trials. So the paradigm to date has been that screening, again, putting on my like epi hat, if you're going to screen, you never want to do screening for disease unless you have a therapy. Like, it doesn't make sense to do it, or unless you have an intervention of some sort, because we could screen people for all sorts of things and it wouldn't be good. And you also don't want to screen the child for disease who's under the until they're old enough to consent, if it's something that can wait. And so those things are things to think about. And so these guidelines currently are talking about doing it in research, which is great. And then also looking at the people who are highest risk, who are the first degree family members, who in general have between a 3 and 7% risk of developing diabetes once there's a proband with diabetes. But it's important to think about, and that's why we're excited we're on this cusp about screening for T1D in the general population, because the other thing we know, and all of us who take care of people with type 1 know, is that 93% of people diagnosed with type 1 don't have a family history of type 1. So by only screening people who have family histories of type 1, we're going to miss 93% of the population with type 1 of new onset. So there are 2 now nationally available screening programs. One has been around for many years, which came out of what Frank talked about, the diabetes prevention trial 1. So the DPT1 its genesis was based upon a very small study that showed that giving people insulin prior to the diagnosis of diabetes could delay the onset of diabetes. Fast forward 25 years, we're basically still having the same discussion as to whether insulin given orally can make any difference in the pathogenesis of type 1, but rest assured it was not a home run therapy. But it still comes up as something we can do in combinatorial therapies, which is outside of the realm of this talk. But anyway, out of the DPT1s, when those studies came out now 20 years ago, saying that that oral insulin was not effective and that intravenous insulin was not effective. Out of that came a group called Type 1 Diabetes TrialNet that I've now been part of for the last 11 years. And some of you at your sites, like Idaho Falls, I remember like some of you have TrialNet at your sites. And TrialNet is a type 1 diabetes research-based screening, NIH funded, completely confidential, completely free clinical trial program for individuals who have a higher risk of developing diabetes based upon family history. So you have to have a first, second, or third degree relative with type 1. Or now, this was changed a couple of years ago, if you've been randomly screened for autoantibodies for some reason. So you have another autoimmune disease and your doctor, which is not generally recommended, not something I would recommend as a clinician. They've checked for diabetes antibodies for some reason, or there was a blood sugar that was high and somebody just checked the antibodies. If you have antibodies that have been detected outside of TrialNet and you're in that age range, you can come to TrialNet and we'll repeat your antibodies. And if you're positive, we will let you know if there's a research trial you can join. But that's what's been available basically for almost 20 years. T1 Detect is the new initiative that JDRF has started, which is kind of what's framing some of this discussion now. And this is an initiative to increase awareness and education about screening for risk in the type 1 diabetes and healthcare provider communities, which is part of why we're here today, but also to provide the general population with access to in-home T1D risk screening for people over 1 year. So you can see that people at 1 year to 2.5 years of age would not fall into TrialNet, but can be screened from T1 Detect, and people without a family member of type 1 can be screened in T1 Detect. So it's a different, and we'll talk about the other differences in the programs. You want to go ahead?
Just to interject.
Oh yeah, please.
If someone screens positive in T1 Detect, they should go right to TrialNet.
Oh yeah. if they're between the ages of 2.5.
Well, yeah, if they fit within that. Yep.
We've talked. Yeah, but yes, that's the idea. So this is kind of, there are slightly different screening programs. So basically the antibodies that are screened in T1 Detect are, I just, on the right-hand side, I stuck in here just a picture showing an islet, and then the ICA, which is just the islet cell antigen, which is just a general immunofluorescence stain. You either light up or you don't light up. I'm not an immunologist, so Frank, you have to excuse me because okay, you have at least a PhD. I do not have a PhD, but it's a very general screen, and that is actually neither of these start with this as first line because it's very time intensive and it's pretty sensitive, but it's not necessarily so specific. And then there's other more specific beta cell directed or pancreatic autoantibodies, so zinc transporter 8, IA2, which is like a tyrosine phosphorylase, I think you're directing it to, and then GAD, which is the most non-specific, but the most common antibody. And then you can have insulin autoantibodies, either to your own insulin or to exogenous insulin. So those are those different antibodies. So going to the left-hand side, so T1 detects that screening 3. I think this is probably based upon, Frank would know better, like the TrialNet screening paradigm, which was initially that we did for many years. And in fact, until very recently, we looked at GAD, IAA, IA2A. We used to also do ICA and TrialNet. And then eventually T1 Detect will pick up more, but there's 3 that you get at screening there. In TrialNet, based upon a lot of data of having done this for 20 years and knowing what tended to be positive and what was the most accurate in our hands, we stuck with GAD. We just do GAD and IAA. And if you have either one of those 2, then you get the whole panel, including that kind of very specialized ICA antibody. But that's the screening. Either way, you get antibodies. To the lay person, to the person getting their blood drawn, to most of us, it probably doesn't matter which ones, but just you get good antibody testing through either one. Next one. And then the way that the antibodies are collected are slightly different. So in T1 Detect, there's an in-home test kit. The patient collects a finger stick blood sample on a capillary paper. So it's more like a newborn screen where you do a poke and you kind of fill a square. And then TrialNet, we do something similar where there's a fingernet blood sample, but then you have to fill a very small tube. So it's a little bit more blood volume, but it allows us to detect the insulin antibodies more accurately in our lab than the capillary. It's not that one lab's better than the other, it's just the assay that's used. Or in TrialNet, we do the old-fashioned blood draw, where you can either receive a kit in the mail and then go to a lab for blood draw, or if you have a TrialNet center near you, you can show up at a center and we will draw your blood. And for TrialNet, the test is, like I said, completely free. We're bound by a certificate of confidentiality from the NIH that we cannot release your results to anybody. For T1 Detect, the test is $55 if you want to pay out of pocket. Some insurers will pay for it, although then you may run the risk of not having that confidentiality around it. Or if you cannot afford the $55, there's a really great literature that says if you give somebody completely for free, they will not follow through. And whereas if you make people pay a very nominal amount, so there's a nominal charge, which is a typical charge of $10 if you cannot afford the 55. Frank's nodding, so I think I'm getting the philosophy. I was not part of the development of that payment structure, but it's what I'm very familiar with. Okay, so then benefits of screening. This is still me, right, Frank? I forget where we switch again.
I forget. How about we switch here and I'll
I don't remember where we switch. Sorry.
It's okay. So let's just reiterate here. So what we want to do with screening, what TrialNet's been doing with screening, we want to prevent what can be a traumatic diagnosis for people, for the patients and their families. Being diagnosed out of the blue is really scary and can be dangerous. So we can reduce the danger, reduce the psychological trauma. We can drive down that incidence of DKA diagnosis. We can teach people about caregivers, the clinical staff around these people, what are the symptoms to look for if a person's in the at-risk category. We can also introduce the people to who are the healthcare professionals they need to have around them. What is that clinical care team they need to build? What information do they have to have on hand to equip them for a life with T1D? We also are going to give them time. We're going to give them time to prepare for this diagnosis. That is important. Not to have everything thrown on top of them during 48, 72 a week in the hospital when their child is hooked up to pumps and glucose strips and what have you, and they're trying to learn everything they need to do with meals and test strips. So we can buy people time and we can give them support. Also, there are clinical trials and more and more and more becoming available with therapies that could potentially help these people. Also, on the horizon is potentially the approval of what is the first therapy that can delay the onset of type 1 diabetes. Not entirely prevent, delay. It's called teplizumab, and it's sitting at the FDA right now. So we're hoping maybe in the course of the next year, we'll see an approval of that therapy for people at risk for developing type 1 diabetes. Just to give you an idea of all the therapies that are in development right now, and this is not comprehensive, but there are therapies in development for almost every stage of the disease. And I have teplizumab highlighted there because it is the one that is the most advanced right now, for which we all have a lot of hope in. But right behind it are other therapies that have just as much potential. Therapies that are directed at every stage of the disease, therapies that could prevent, halt, or reverse the loss of the beta cells, and therapies that are directed at the immune system, the beta cells themselves, or both. A lot of these trials, especially these stage 1 and stage 2 trials, would not be happening without TrialNet. TrialNet has been singularly responsible for running stage 1 and stage 2 trials here in the United States. So without getting screened, these at-risk individuals would not know if they're candidates for these therapies that could potentially delay the onset of their disease. Many of these trials, hydroxychloroquine, abatacept, oral insulin, these are very safe therapies. They've been judiciously chosen for safety and the potential for efficacy by a lot of really intelligent individuals. So fingers crossed, teplizumab will make it to the goal, and that its follow-ons will have similar success. So just a little bit about the teplizumab results, since it is a hot topic these days. Teplizumab is a monoclonal antibody to CD3, a protein on the surface of T cells. And what was shown in a phase 2 clinical study with follow-up was that patients who received a single course, a 14-day course of teplizumab or placebo, had a delay of their progression to T1D by almost 3 years. These patients were stage 2 individuals. That is, they had 2 autoantibodies or more, and they had dysglycemia. And those patients did not progress to overt type 1 diabetes, or the responders. I think it's about 50% of them were responders. And some of them, 3 years to the day, still don't have type 1 diabetes, while the placebo-treated do. This has never happened before. This is the first time we have ever seen anything that can delay the onset of this disease. This is a fundamental change to how we're going to look at the prevention of this disease. I know Linda and her colleagues are quickly trying to figure out how they're going to think about this in the context of this population going forward, if and when this is approved. So right now, there are 2 studies to be aware of for this population. Currently enrolling is the hydroxychloroquine study for stage 1 individuals. This is an anti-malarial that has been shown to have efficacy in reducing symptoms of other autoimmune diseases, and in preclinical studies demonstrated a lot of efficacy for type 1 diabetes, and very, very, very safe drug, and has now been recruiting for stage 1 individuals in TrialNet. I think it's getting close to finishing recruitment, at which point they'll turn over to abatacept as the next study that they recruit for both stage 1 and stage 2 individuals in TrialNet. And abatacept is a slightly different drug. It's targeting the co-stimulation cascade of the immune system. So it's meant to block activation of T cells. And again, there's been great clinical data here showing that it reduces the loss of beta cell function in people with recent onset disease. So
Yeah, let me
this
just
one will be under. Yeah, go ahead.
I'll just pause you. So the abatacept study is actually not enrolling because we're waiting to do it because we're already done. So it's all enrolled and we're waiting for primary outcome. No, just so you know, it's all enrolled, it's done. It was done looking at progression from stage 1 to stage 2, but that's why. I don't know that we know yet what's next on the horizon, which is part of why hydroxychloroquine is still open, but there's other things that might be. No, it's good.
I wish we did know what was next on the horizon. So anyway,
I know we're
update when we
talking. I'm
know
actually on the
that.
committee that's helping figure out what next to do with abatacept, depending on if it works or doesn't work and all of that. But yeah, we have that was completely enrolled, and I think those results should come out maybe even this fall or next spring. So we'll have them soon.
Oh, so
That's why
actually
tag
excellent.
teaming is good, Frank.
Oh, good. So actually keep your eyes peeled for the
Yeah,
abatacept
watch and see. I have no answers. I kind of know we're talking about what to do again in stage 2, and we're in the process of voting. And if I knew the vote results, I couldn't tell you, but also we're like, I don't know them yet. Like the deadline to vote was today, but stage 1, we're still figuring out too. So, but there's other things coming.
Very cool. And down here on the bottom, TrialNet is a great website to go to. There's always an updated list of what's an available trial. And we'll point out some more of those resources later. Some of the cool trials going on in the recent onset setting we should point out are the PROTECT trial, which is using teplizumab in the stage 3 population, people recently diagnosed, to see if it can continue This has been demonstrated before, but this is a large phase 3 study to show that it slows the progression of type 1 diabetes in the recently diagnosed. Another cool study that's currently recruiting is a kind of a combination study that's looking at a combination of a hybrid closed loop device system with a beta cell survival agent, verapamil. And it has arms that are single agents of both. You can get a closed loop, or you can get verapamil, or you can get the combination of both. And this is recruiting down pretty young. And then one of the newer ones is it's a safety study for a tolerance-inducing plasmid. It's a plasmid similar to what was used for our COVID vaccine strategies, where the plasmid is expressing insulin or pro-insulin in the liver. It's a Novo Nordisk trial. Right now, it's just a safety trial, but once they demonstrate safety, they'll start eking that back further in disease to really see if it can delay the onset of type 1 diabetes. And really, this is like an amazing direction to go in. This is really re-educating the immune system in a way that should be have minimal side effects and hopefully lots of efficacy, but we'll wait and see. Let's see, I froze a little there. And I want to point out where you can find more information about clinical trials for your patients. JDRF has a tool, a clinical trial matching tool that is geared towards people with T1D. You can go in and put in your T1D characteristics. Do you currently have T1D? How long have you had T1D? Are you on insulin? How much insulin do you take? What's your HbA1c, family history, number of autoantibodies? Where do you live? Everything. And it'll pop out what's available to you. Basically, it pours through the NIH clinical trials website using a tool called Antidote that we use as a vendor. I mentioned already TrialNet's own website. They always list both prevention studies and recent onset studies. So these are really important websites to be aware of and to make your patients aware of. And then I'm going to kick it over to Linda again.
So so there's some limitations to screening, some of which we've alluded to before, but we just wanted to take you through them here. And so because we don't want to try to come across here as saying that, you know, you should rush out and screen everybody without thinking at least about these things and kind of how they're supposed to be messaged. So it's important. This is actually something I've been interested in for, I don't know, 11 years since I joined TrialNet. Actually, the screening results cannot tell people precisely when they will develop diabetes. I think we now know that they will develop diabetes if they live long enough. Once you have 2 or more multiple autoantibodies, so your year-over-year risk, you have a 30% risk. This number I have them at 30% first 5 years, then 30% of the survivors the next, et cetera. So if you keep doing that, you get to 100% eventually. But all you know is how many autoantibodies you have on the day you take your test, and this helps us predict risk. But the number and presence can change with time. And actually, TrialNet's looking now at some of the people who lose autoantibodies. It's not very common to lose them, but it can happen over time. And the results have to be confirmed. So as Frank emphasized this earlier. So if you do screening, so in TrialNet, we're using a research lab that group has used for 20 years. So if you have more than one autoantibody, we don't confirm it. But if you just one, the next step is to confirm. With T1 Detect, the plan is to immediately confirm it in another lab because it's a newer lab, and make sure. And then you have to figure out then what stage of diabetes you are by metabolic testing, mostly like an OGTT. So one of our faculty here was diagnosed during the diabetes prevention trial when she showed up she had found antibodies based on screening. I forget who in her family had type 1. And at 8, she came in for OGTT and she had diabetes. So that's how she was diagnosed. Not in DK, which was great, but she was diagnosed in the DPT1. And the results can cause increased anxiety and psychological distress. And we're fortunate that we partner with a number of psychologists in this area. And but we do know is that just like there's distress at the time of diagnosis of diabetes, that there's also distress and anxiety at the time of you're told your child has antibodies, or you're told you have antibodies, and you may develop you'll develop type 1 over time. But education and counseling reduce this, and most families, in hindsight, don't regret having been tested. There's a shock associated with it. There's no approved monitoring guidelines. They will in the future, and it's a hot topic right now is kind of figuring out what to do. But the recommendations that I'll take you through stem from the experience of a couple of us who are experts in the field. And there's no FDA approved or commercially available treatments. So I told you that that's a kind of a cardinal rule of screening is you don't screen unless you can treat or unless you can avoid disease. Frank gave you the case around avoiding DKA. I think we will be able to say that we're also going to have a treatment to slow the progression soon for people that are at stage 2 of diabetes. The application for teplizumab was submitted in November 2020. There, if you go online, you can find readily the information about the advisory meeting that happened in May, which basically FDA voted that the delay in type 1 was a valid reason to move forward with approval in this indication. And now there's a whole nother set of things that they need to live up to be able to do this. But anyway, I think that's going to happen. And we're anticipating that will happen in the next year without like owning stock in prevention or anything like that, because I would not use it as financial advice that I think that's going to happen. But I think on the other hand, I think that's likely. Frank, go ahead. So we do have, so this is what I started talking about a little bit earlier. We do have information from these prospective cohort studies of children with genetic risk of type 1 diabetes. And what we know is that 10 years of follow-up, so this at 30% kind of rule, more or less, children will go maybe a little faster. I said that earlier. So over 10 years, about 70% of children with multiple antibodies would progress to type 1 diabetes. This is in a setting of increased genetic risk. And then about 14% of one antibody. So one antibody is a lot less predictive, but still worthy of monitoring. And then all those who have seroconversion, if you're less than 3 years of age, you progress more rapidly than kids over 3 years of age. So I think the guidelines, when they come out, are going to incorporate age into the screening recommendations. But if you're under 3, your 10-year risk, if you have autoantibodies, about 75%, over 3, 60%. If you went over 18, it would be even a little bit lower than that. So just be aware of that. Next slide. So here's just some ideas of ways to look at follow-up and monitoring. So if you're antibody negative, you could rescreen if there's diabetes-like symptoms, and you could consider rescreening based upon your incidence data and also what we know about the development of autoantibodies. At age 5, if you're less than 5 at the first screen, at age 11, if age 5 to 10 at the first screen. I would say this is going to only be in people that are like either, I don't know, really keen to know again and really keen to rescreen again. We've had a lot of talk within TrialNet about the optimal age of first screening. We are screening down to the age of 2.5 because the hydroxychloroquine trial is currently enrolling starting at age 3, and that gives us 6 months to get somebody into a trial. I can tell you if we didn't have tried hydroxychloroquine open, we would probably screen potentially a little older age the first time, but there's not, there are some data, but if you, we also know if you screen negative in a good lab, you're not that likely to convert, which is why TrialNet stopped like doing annual rescreening, which is what we used to do. But anyways, but you can consider rescreening again. This is related to the ages at which people develop antibodies. If you're confirmed single autoantibody positive and your blood and your A1C is normal, the recommendation would be to follow up about every 6 months with repeat metabolic testing. Again, knowing you only have a 14% risk over those years, but you would do it initially just to see, are you catching somebody on the, are they going to develop in these guidelines, which came from Marian Ruer's in part, and then I adapted them a little bit. There's not a recommendation for repeat autoantibody screening, but it might be interesting to repeat your autoantibodies and see if you're developing more early on. But then once you're a single autoantibody positive for 2 years, then you could be followed annually. But the following up is doing either an A1C, an OGTT, or for people that don't want to undergo an OGTT, you could do a fasting and a 2-hour postprandial blood sugar. So what I tend to do is I will give people a meter at some point, not necessarily single autoantibody, but when we get to multiple antibodies, and I'll say, test yourself 2 hours after your biggest meal of the day, whatever that is. And that's a reasonable surrogate for like an OGTT. Note, firstly, it says confirmed single autoantibody positive. And secondly, if you have patients who are on antibody positive, you can refer them to TrialNet, and we will be happy to see them, and we'll be happy to help you with them. All right, so then the next is of talking about multiple autoantibody. This one's a little bit more complicated, but if you're stage 1 diabetes, so if you have multiple autoantibodies but still normal blood sugars, the plan and what we do in TrialNet is we follow those patients every 6 months We do OGTT, we do oral fasting and postprandial blood sugar. We actually do it. We test an A1C. That's how we know that they're in stage 1. So you've got to follow the A1C. And you basically would tell people to call or let somebody know if there's any diabetes symptoms, and we counsel them on that. If you've got stage 2, so that's the group that was treated with teplizumab, they're multiple autoantibody positive, and they're pre-diabetes, which is more of an adult term that I don't use as much as a pediatrician. So what I think about is your fasting glucose is less than 126, but over 100, your 2-hour glucose 140 to 199 after no GTT, your A1C is between 5 and 6.5. Here we would recommend early type 1 diabetes education. In our hands, that would be meter teaching. So you can tech occasionally at home. Some dietary teaching. We're planning on having, we're developing a program here. We're going to have some nutrition therapy for these families. Some families when they're in this stage will say, well, I'm just gonna let my kid eat anything because they're gonna get diabetes and they can eat nothing. So we want to make sure that they can know that they can eat a balanced diet along the way and train them a little bit on carbs just so they have a plan on that. And then check fasting a 2-hour post largest meal blood sugar once a week. You can put people on continuous glucose monitors now or use strips. And I also recommend that people check if they're sick at all. That can be a time when the blood sugars are high and then can come back down to normal, but also it's just a good check just to make sure you're not going into DKA. If the blood glucose is over 200 milligrams per deciliter times 2, or there's symptoms, you'd follow up with an endocrinologist. And these people are on the cusp of developing diabetes. Their 5-year risk is more like 70%. So the plan is to follow them every 3 months initially. And then if you have diabetes, so this is a little bit tricky. So some people that you identify with screening and you find they have diabetes, they actually might not eat insulin right away. Their A1C could be like 6.6, and they might come in with fasting blood sugars of 100 every day. But what you want to see is you assess them for polyuria, polydipsia, weight loss, fatigue, obviously DKA. Most people who have stage 3 diabetes will need to start insulin on that day. And that's our clinical experience, is that we start them on insulin right away. These people will absolutely need meter teaching or CGM, even if you're not going to put them on insulin, so that you can monitor for need of insulin. And you'll need to refer to an endocrinologist for follow-up. Again, anybody that—
There's a question here from Trudy on that note. You know, from a family that's brand new diagnosed, within the first 24 hours, they're resistant to or not absorbing education.
Yep.
And you as a healthcare provider are giving them what you can for education, basic survival info.
Yep.
What is the one thing that you really want them to take home with them to like, what's that one thing you're emphasizing that they need to get in that first 24 or 48 hours?
So I think the one thing I say to every family that's newly diagnosed with diabetes clinically is that these kids can do anything they want in their lives with diabetes, that it shouldn't interfere with their ability to live a long and healthy life in any way, that hopefully this hospitalization, even if they've been in DK, will be their last hospitalization for diabetes. I asked the kid what they're interested in. Do they like sports? Okay, these sports figures have had diabetes. Do they like movies? These movie people have had diabetes. Justin Bieber has type 1 diabetes. Like, people that are amazing have type 1 diabetes. And I try to make sure that they know that they need to fit diabetes into their lives, but their lives should not revolve around diabetes. And that's like my number one message. From a medical perspective, I would say the number one message that they have to get is that they need insulin, and that they will need insulin for the rest of their lives right now, unless Frank and some of the people doing islet work really fix this, and that there's no way around that. I tell them that the way we used to take care of diabetes, hopefully I don't look that old to them. I was referred by somebody in Chicago as an older couple this weekend with my husband. So maybe I do look older, but I say, the way I've watched this evolve in the last 20, 25 years has been tremendous, that we have great technology, but they need insulin. We did have one kid who came into a study where we used metformin in type 1, who decided he didn't need to take his insulin anymore because he was now on metformin. We're like, that didn't work out well for him, of course. But anyway, that's kind of a major point. And then really dietary education and just figuring out the kid. One of my first questions in my clinic with my patients, especially when they're struggling, is like, tell me about your life with diabetes. What's the first thing you do in the morning? Like, when's the first time you think about your diabetes? What do you do? I had one kid I was like, he couldn't test his blood sugars at bedtime. And I said, tell me about how you're testing about your bedtime. Well, he was going upstairs, brushing his teeth, and then going back down to the kitchen to like test his blood sugar, and then going back up. I'm like, well, what if you test before you brush your teeth, or you bring the meter upstairs, and just ways to fit it in. And I also tell them that that no food is off limits with type 1. There's just portions are important, because I think that's also really important. And just letting them know. And I hired one of the people I had seen in the hospital as a study coordinator a few years ago. I don't remember. I wish I remembered her from like her hospitalization. And she said that her mother like remembered that I had given them the talk around you can do anything in your life with diabetes. So hopefully that answers.
Great, Linda, you nailed it. Yeah.
Okay.
Yeah, Trudy's
I've
saying
not
that
done
those
this
are
talk
great.
before, so we're learning from each other as we go along.
No, but Trudy's saying you did great point. Those are great points. Yeah, thank you so much.
Oh yeah.
So I think I'm going to take the next slide from you, Linda,
Yep,
and try and wrap it up so we have some time for questions. Listen, I want to reiterate here that there are tons of resources available for you and your families. I mentioned TrialNet, I mentioned JDRF. We have resources on our online. Linda is here representing an organization that is just chock full of resources. So you can reach out to her or reach out to TrialNet to get your hands on them. Reach out to your local TrialNet coordinator to get your hands on them. JDRF has both online and physical support teams. We have volunteer staff who have lived through this, who are willing to talk to people who are newly diagnosed or talk to people who are going through this risk assessment decision. Avail yourselves of them. And again, TrialNet has people like this as well. The personal touch of a person who's lived through this situation is really important. There's only so much that I, as a scientist, can explain to a person who's getting ready to make this decision or is living through it. But to hear from a person who's lived it is really important. We don't want to overemphasize or underemphasize the importance of mental health care during this process. The ADA has done a really good job of curating a list of diabetes-specific mental health providers. These are not necessarily type 1 diabetes specific, but they are mental health providers who understand diabetes. We're working, if people want to contact us at JDRF, we do have a curated list of T1D specific mental health care providers, and it sounds like TrialNet also has a resource there. So we can offer that sort of personalized connection if needed. Something that's on the horizon is one of the research-based general population screening programs here in the United States called the ASK program in Colorado. They're ready to launch a spin-out, which is called Ask the Experts, which they're going to use their faculty, their educators, their resources, and make them available to the healthcare provider and patient community here in the United States. Now, this is not going to be officially telemedicine, but this is going to be available for consultation. And this is a program that's funded through a partner organization of ours called the Helmsley Charitable Trust to address these needs. Sometimes people or even healthcare providers have questions they can't get a quick answer to. And this will be one of the resources that should help them if they can't get a quick answer. So this should go live in the next couple of months. Another set of resources, and this is more specific to you as healthcare providers, are a set of materials that actually reflect a lot of what we talked about today, that we worked with a company called MedIQ to put together in a way that serves as accredited learning for you, CME accredited learning. So these look like a series of modules that you can view and get course credit for. The link is here, and we'll leave you with these decks so you'll have all live links. And finally, I just want to, in summary, leave you with a couple points. We know right now that DKA diagnosis, it looks like pretty well that it can be prevented with autoantibody screening and monitoring. We know that from research-based programs, and it's our goal as an organization, as a JDRF organization, to make sure that we start doing this in clinical practice. Through TrialNet and through T1 Detect, your patients can access autoantibody screening if they so desire. So if they're a first-degree family member, I think you probably should encourage them to go to their other family members screened through TrialNet. If they're a general population, you can offer them the information about T1 Detect. I mentioned the resources available to you to help you learn more about this, and they include, like Linda so well talked about, these monitoring recommendations and stuff, so you can access them there. And all this is with us knowing that on the horizon there will be therapies for this population. So we need to start preparing ourselves as a medical community to identify these patients early, so that we can provide them the therapies that will buy them years of not being insulin dependent. So with that, I thank you so very much for the time. And I hope we have a couple minutes still. We do have a couple minutes for some Q&A. I saw only the one real question from Trudy, but anyone else, please shoot them our way, any questions you have. Right, stop sharing, go to full screen.
Thank you both so
Thanks,
much for that
Linda.
presentation. That was super informative, very exciting information coming out. So yeah, as mentioned, I'm gonna just open up the lines if you want to unmute yourself to answer or to ask any questions of our speakers, or if you want to use the chat function, please feel free to do that as well. A couple of questions already come in. Will the slides be available? Yes,
Yep.
They will be available. Lots of accolades. Fantastic information. Thank you both so much. I was wondering if we could provide a little bit of information around the opportunity for clinics in Idaho to get involved with this T1 Detect screening program. I know that we have a couple of FQHCs on the line, as well as some primary care representatives. And so diving into what can we do, kind of as a follow-up to your last slide, are you able to provide a little bit of information on if clinics are interested, what that could look like as far as this trial program?
Sure. So I'll start, and I think my colleagues Katie and Amanda, if they're on, can chime in. So first and foremost, I think your clinics should reestablish or newly establish their connection with their local TrialNet site. And for your first degree family members, make sure that they're going there. That is an established program that does what they do for the first degree family members. That's the way to go. For people who are interested in the general population screening, we have all these resources that we can make readily available to you on communication packages. We actually are working with TrialNet now to make sure the communication and information packets we provide to patients are aligned with their well-developed messaging. We have information and education for medical doctors. You've seen some of that comes from the MedIQ. And then we actually have the test kits themselves. So the way we do it now is we send people to a web page and they have the kit sent at home. But we're also able to, if you want, sort of stock your clinics with kits. Something that's a very high priority to us is being able to reach people who are not being normally reached by our programs. So people who, I pointed out the Hispanic and Black populations who have terrible rates of DKA diagnosis. There's also people in rural settings are not accessing these screening programs as well as those in city settings. Hence the benefits, TrialNet's doing it as well. The at-home testing has really helped that. So strategies around making this more accessible to people in rural settings or people in underserved populations is very interesting to us, and we're willing to work with you to set up the resources at your clinics to make that more possible. Something that I won't, Linda spoke a lot about this, having your clinic's monitoring plan well established is probably something you should have planned beforehand. How are we going to deal with these people when they start coming in? Are we going to hand them over to a partner at TrialNet, or are we going to handle them ourselves? And how are we going to do that? That would be important to set up. I think I'll ask Katie and Amanda to probably embellish further.
Yeah, hi. Hi, everyone. I'm Amanda Gottlieb. I'm on the marketing team at JDRF, but I'm also part of the working group for our T1 Detect program. So like Frank said, we're also hoping to explore a pilot program with a clinic, and we're especially looking to reach kind of underserved populations or populations with lower socioeconomic statuses, because we know that that can be a barrier. So with a pilot, you know, we would work with you and have some discovery conversations about what kind of the logistics and pathways could look like for patients, and having the kits at your clinic or having them order, help with ordering assistance. But essentially we would also want to subsidize the kits completely to remove that cost barrier. Because right now this is an at-home, a male, you know, at-home kit. We haven't tested it out yet in a clinical setting, so hence the need for a pilot. So we would want to kind of gain some insights from you as well, and kind of work together, and maybe do like a 1 to 2 month kind of pilot. But again, if there is any interest there, we're hoping that if you could reach out to Ashley, she would actually be able to connect you then with us, and we could have more conversations as well.
Thank you both for just sharing some additional information around what that can look like. So those of you that represent some of our primary care clinics and our FQHCs here in Idaho, if you're interested in being part of this pilot project, and kind of being at the forefront of this new research that's coming out, I really encourage you to reach out to me. Send me an email. You should have my email address, ashley@diabetesallianceofidaho.org. I'll also provide some information in a follow-up email that'll include different links and different information for you to reference as you make that decision. But I think that there's a few clinics that I already have in mind that I think would fit this opportunity perfectly. And so I might reach out to you individually if I don't hear from you first. So if this is something you're interested in, as I already said, go ahead and send me an email, and then I'll get you connected with Amanda and the team to establish what those next steps would look like. From what I've been told, costs would be reimbursed. And there would be a lot of support in rolling out this pilot project. So if anything, feel free to ask a lot of questions and see if it's a good fit for you and your clinic. So we did have another question come in. What is the shelf life for these kits? We have many patients who have limited access to internet and difficulty using it.
So the shelf life should be forever, because it's just a piece of paper and a lancet. That there's no liquids or anything that you have to worry about. The internet accessibility issue, there is like a QR code that the person would use to register their kit before they send it back in the mail, but that could be done anywhere, you know. So if they're coming to you in the clinic, you could help them register. They could bring their kit to you. There's a way, I'm sure there's a way around that. And even if we could probably work it so that there's a form in there, written form with enough information that just gets sent back to the company for running of the test. It's not like it's going to be a 10,000 tests. So that's an easy workaround. If they have a phone, it's simple enough to do all the login information for the kit. You don't necessarily have to have internet other than through your phone. Understanding that might be a barrier in of itself for some people.
I think that's a fitting question too when talking about this pilot project that we're hoping to roll out is, And to be honest, Susan Goody Adams, the Adams County Clinic was actually one that was in my mind of a potential partnership to roll this out. So having access to the clinic, being able to work with you all as medical professionals, maybe that there could be that communication with the patients and coming back to the clinic to help register that kit or providing those technical difficulties. So, or that technical assistance, I should say. Any other questions? I know we're hugging 1 o'clock here, Mountain Standard Time. So if anyone has any additional questions, please feel free to throw them in the chat box. It looks like Amanda also shared a couple of the links for the CE opportunities. Those will also be sent out in a follow-up email. So. Susan, you'll be hearing from me.
Well, Ashley, I want to thank you again for the opportunity, and everyone on the phone. And I especially thank you, Linda, for taking the time to build that presentation with me. And we'll do this again, Linda.
No, it's a pleasure. I am
you.
indebted to it's great to meet this community. I have been to Idaho only once, but I hope to come back. So it's nice to see some people in mountains, being in the flat Midwest. And yeah, I have been JDRF funded my entire career, and I am very indebted to JDRF for everything they're doing for people with diabetes and the patients that I serve. So it's been great. Thank you, guys.
Wonderful. Well, thank you both for just sharing this information with us and taking the time to present this information. I will be sending follow-up emails. I will be collecting any additional questions and be sure to get those out via email. And we hope that our paths cross again soon. Thank you all for the work that you're doing to serve our populations with diabetes. And with that being said, I will go ahead and wrap up this call. And if anyone has any questions, please feel free to send me an email. Please be sure to visit diabetesallianceofidaho.org and register for our July training. With that being said, you all have a great rest of your afternoon, and I look forward to talking to you shortly. Thank you.
Take care.
Bye, thanks.